All right, so good morning, everyone. I'm Paul Kirby, one of the fellows, giving a couple of these lectures this year. Luckily, sticking around over the next few years, so hopefully y'all get to hear from me a couple times. For today, we're doing cases in resuscitation. I'm doing critical decisions and critical situations is what I titled this talk. Wanted to kind of work through a couple of things, and you'll figure out kind of a little bit more of a theme today. But if you can imagine you're dispatched on someone with difficulty breathing, if you're like me, whenever you get a dispatch or a pre-arrival, you start running through in your head what this could possibly be. And I think that's important to do so you anticipate the worst and you start anticipating what you need to do. So for difficulty breathing, it could be asthma, it could be COPD, it could be COVID flu, aspiration, choking, it could be heart failure. But while you're en route to this difficulty breathing, hopefully you're thinking about things. Is this an asthma exacerbation? What would I need to give? Do I need to give breathing treatments? Do I need to give steroids? Is it their heart? Are they warm? Are they cold? Do I need to give fluids? Not. Is it just COVID flu? Is it a turkey sandwich run type things? All these things you're thinking through. And what's interesting is the difficulty breathing is missing one thing in my mind, right? So we're dispatched on difficulty breathing. Oh, it is going to play, and you get a guy like this. You don't see all this, but you get a report that he apparently fell down on the ground, did a little bit of shaking. Then he did this type of breathing where he's like, non-life sustaining breathing, right? We call that agonal breathing, guppy breathing, right? But this is going to be dispatched as difficulty breathing. In y'all's mind right now, hopefully you're thinking that guy's dead. We need to start doing CPR. But for the bystander, for the dispatcher that's hearing all that, they might not catch that. So if you're not thinking and prepared for that, you're going to miss that on the way in for this difficulty breathing. So ideally, you get to this patient, you're not immediately going to do something like this, unless you really, really like them. You're probably going to do the look, listen, feel for a pulse, and then you're going to start some CPR. You're going to start CPR, do some high quality stuff, maybe stimulate the brain a little bit, try to get a kickstart right there. You're going to do some good stuff. I want to take a detour now. So we've started CPR on this difficulty breathing that we were dispatched on. I looked it up a little bit. So the reason my talk today is going to be a lot of resuscitation for cardiac arrest is because I'm going to the Resuscitation Academy, their class up in Seattle at the end of the month, and learn how they do it so well and how their rates of success are so much better than ours here in Alabama. So if you can imagine, I don't know if y'all have ever seen, but I've been to the 911 call centers. There's screens everywhere. They're dealing with all these calls, and it's honestly just system overload looking at everything. There's a really cool movie that I like called The Guilty with Jake Gyllenhaal. Don't know if anyone's seen it, but essentially about a cop that he gets like demoted, he gets in trouble, he's going to court, and they put him on the 911 dispatch almost as punishment. And he's sitting here listening to all these calls, and he gets into this intense call, and it's a really good movie, but it just kind of shows you what they're dealing with each and every day. And I looked up a couple articles about 911 dispatch and, how likely is it that a patient in cardiac arrest is going to be missed essentially based off the dispatch call. So if you can imagine, this study looked at, I think, about 370 cases by the end of it where they sat there and listened to the dispatch calls and what was being described. So if they asked the person that called them, is the patient breathing or not? They got all these different answers. Are they breathing? No. Nope. Don't think so. Don't believe so. Doesn't look like it. Doesn't seem to be. Maybe. Right? Like that's pretty confusing to hear. Well, then they take it a step further. It's like, can you describe what you're seeing for me? Well, they're hardly breathing. They're not breathing. They're sort of breathing. They're breathless. They're short of breath. They're taking big breaths. They're erratic, sporadic, irregular. It's kind of a problem, right? This is a huge language here, and it goes even further. So then they're like, describe the sound they're giving. They're gasping, gulping, gurgling, panting, raspy, short, snort. Lips are blue, face is blue, turning purple. So there's all these different descriptions that our 911 dispatch team sitting here listening to, and they're trying to weed out, does this patient have a pulse or not? Do they need to start CPR? Who do they need to send to the scene? And then they analyzed this. So they analyzed if they said they're breathing or not breathing. They dispatched it as out of hospital cardiac arrest. And was it a true out of hospital cardiac arrest? I don't want to go through this too much. I just want you to realize that for each one of these descriptors, and even if they said they were breathing, they were dispatched as cardiac arrest and they turned out to be true cardiac arrest. So in my mind, each one of these complaints at some point in time or descriptions were a true cardiac arrest. So my takeaway for this is that if you're dispatched on a difficulty breathing, you probably need to be thinking about cardiac arrest and preparing for that. That makes sense? Makes sense? And then I looked into the Alabama's dispatch protocols, which I think you can find online. I think I found the right ones. But essentially, they're going to do exactly what I just kind of talked through. They're going to see, is the patient breathing? Do they respond to you? Do they answer you? They're asking all these questions. If they're unconscious, then you go to the airway control. If they're unconscious and not breathing normally, you go to the CPR instructions. And this is kind of where it kind of gets alarming, but I don't have any suggestions. Do they know CPR? Yes, no. Then if they don't, then you're going to have to instruct them over the phone as the 911 dispatcher to do CPR. But before they start CPR, they have to make sure the door is unlocked. They have to go find an AED. They have to move the patient closer to the phone or move the phone closer to them. So that's a lot of time in a stressful situation before they even start CPR. So why does this matter? To me, this matters because, one, we need to recognize cardiac arrest early and as quickly as possible. If you think about it, as EMS, you guys are probably 4, 5, almost all of these chain or link chains and the links in the chain of survival or whatever. So you're going to be the recognition and emergency activation. You're going to be the high quality CPR. You're going to be the defibrillation. You're going to be some of the resuscitation. You're going to be probably some of the recovery. These people are going to live and they're going to come back and want to shake your hands, take a picture with you. That's going to be part of closure for them. So you're a large part of their recovery in this system. Most of our cardiac arrests that we face are going to be asystolic cardiac arrest. So about 35 to 40%. You're going to run into PEA next at 25 to 35%, and then you're going to have VFib or pulseless VTAC, the least amount, at 20 to 30%. And I think most of this data I got from the CARES data, but I believe if you get all the data from wherever, it's going to be very similar to this right here. So the takeaway from this is that 70 to 80% of all of your cardiac arrests when you arrive on scene are going to be non-shockable, and 20 to 30% are going to be shockable. Okay, follow me? If you look at ROSC rates, so which one of these patients are we going to get back? Well, we're going to get the VFib, pulseless VTAC patients back the most, followed by PEA, followed by asystole. Now, this doesn't mean that we're not going to get the people at the bottom back, but I want to point out that the VFib, VTAC patients are the ones we're going to get back, but they're the ones we see least amount of time. So this is just kind of summarize it. Again, the asystole, the PEA, the VTAC, VFib in order of how many times we're going to see them in the field. And then the survival to discharge, the ROS rates, favorable neurological outcomes, they flip. So if there was a way for us to see these VFib, VTAC patients first, to see them more, then we would probably have more favorable neurological outcomes. Then I sat there and thought about why might some of this data be off, right? Why is it that we are seeing so many patients in asystole and PEA versus VFib, VTAC? And if you think about it, a lot of the VFib, VTAC is going to be caused by some of your heart problems, so a heart attack, a lot of stress on the heart, something to cause the heart to spasm. So you would think you would see more of that. Your PEA and asystole is going to be more of your like hypoxic arrest, your drownings, or your PEs. And then I looked into it a little bit more. There's a theory about the 3 phases of cardiac arrest. The first phase is going to be the electrical phase. Between about 0 to 5 minutes, I saw anywhere from 0 to 4 to 0 to 7 to 0 to 10, but I want to say 0 to 5 minutes. So within 5 minutes of the heart, your heart still has ATP, the energy it needs. It still has some oxygen. There's a bunch of electrical activity still going to the heart. Cellular energy has not progressed yet. So the heart's kind of spasming, trying to get back on track during this 0 to 5 minutes. If you think about it, that's why all the AEDs are within all the athletic gyms. That's why we need AEDs everywhere. because you guys aren't going to see the VFib VTAC most of the time. What's the average response time for EMS? 8 minutes. 8 minutes. So if I say 8 minutes and someone witnessed someone drop down right in front of them, the average time is for 8 minutes for you guys to get there. So that means we are outside of this electrical phase. So they're not going to be an asystole or PEA by the time you get there just based off this. So that's the importance of having AEDs everywhere within reach, right? So that's why AEDs are in schools, because if someone's witnessed going down, they're supposed to grab that, put them on the chest, and listen to what it says to do. The second phase would be your circulatory phase, so about 5 to 10 minutes. And here you start having some oxygen and ATP being depleted, your myocardium becomes ischemic and poorly perfused, and at this point in time, defibrillation isn't necessarily going to work. So the important stuff in this phase from 5 to 10 minutes is high quality CPR. We need to get oxygen and ATP back in that heart. So this is where high quality compressions are important. And there's a couple studies that show that CPR before defibrillation during this phase of time, when y'all arrive, improves the success of the defibrillation. And in my mind, that makes more sense. You add oxygen and ATP into the heart. Third phase is going to be your metabolic phase. So it's anything greater than 10 minutes. And the big takeaway here is that at this point in time, this takes everything you got. You have to do everything perfectly at this point in time. High quality compression, timely defibrillation. This is when you're trying the epinephrine, you're trying to get the airway, all that good stuff. So your takeaway for this is that the electrical phase is the most important phase. These are the patients that are in VFib, VTAC. These are the patients that we can defibrillate. These are the patients that we can get ROSC on most commonly. These are the patients that have the functional neurological outcome. And then for the circulatory phase, high quality compressions. For the metabolic phase, everything you can, as good as you can. And so that was our little detour there. So the big takeaways here is recognize that dispatch may not get it right, but they do get it right a lot of times. VFib, VTAC arrest happens the least, but they have the best overall outcomes. And then many VFib, VTAC arrests may be missed because of that response time. And then cardiac arrest is not a single event, it's a time-dependent disease. So 0 to 5 minutes defibrillation, 5 to 10 chest compressions, and then greater than 10, everything else. So let's go back to the case. You check for a pulse, there is no pulse. And you start CPR. Just like a NASCAR pit stop, right? We're going to do pit crew CPR. There's a lot of data on this. I didn't want to spend too much time on this, but really high quality compressions at 100 to 120, 2 inches deep with full chest recoil is going to be your treatment of choice. And depending on how big of a crew you get, you could have 2, you could have 3, you could have 4. This is just a picture of 4. But the biggest things here is to make sure you train together. Whoever your crew is, you've talked about this. You're dispatching on a difficulty breathing, and you've talked about like, hey, if this is a cardiac arrest, I'll do airway, you get access, I'll feel for a pulse and start compressions. We'll start compressions, we'll roll, we'll put under the pad and get the Lucas going. All these different things. You've trained through this, you've talked about it. That's the big takeaway with pit crew CPR. That's what makes it successful, is that you each have a role and you commit to that role that you've been given. Where it goes wrong is where you don't train consistently. Your roles aren't clearly defined. And a big one here that I've seen out in the field is that scene leadership is missing. So there's not someone in charge. Whoever's there, the paramedic, the senior leader, is just kind of locked in on getting IV access. They're missing the fact that the patient hasn't been bagged for 5 minutes. They're missing the fact that compressions were going, but then they stopped for 30 seconds. So scene leadership is a big one in my opinion. And then some pitfalls include overly complex protocols, which in this case probably aren't that complex. It's just do CPR. So let's talk about this first position right here. This first position probably went up. They saw the patient was on the ground. They felt for a pulse and didn't have a pulse. So they're going to do the best next thing. They're going to start compressions. The biggest thing about compressions is that you generate forward blood flow through 2 mechanisms. One, you're increasing the pressure within the thorax itself, so you're pushing blood that way. And 2, you're pushing blood throughout the heart, so you're compressing the heart between the spine and the sternum. We all know rate of 100, 120, depth about 2 inches, complete recoil, and you want to very much limit the time off the chest. Um, I love the Lucas. I'm a big fan of the Lucas. I think when it's done correctly, when you minimize the time off the chest, it works very well. The problem becomes when you don't do it well. And there's three different trials that I looked through. The Link trial in 2014, the CERC trial in 2015, and the paramedic trial in 2015. Each one of these looked at a mechanical compression device versus manual compression device. The Link and the paramedic looked at the Lucas devices, and they had different primary outcomes, which was their goal, mainly to survival, either 4 hours, 30-day, or survival to discharge. Essentially, each one of these studies showed that there's no difference in survival. In fact, some of them showed that there's a little bit of harm with the mechanical compressions. The biggest thing, the biggest problem, is that we all know about the perfusion of the heart and the brain. Time off the chest. We got to limit time off the chest. So the more CPR you're doing, good quality CPR, you are perfusing pretty good. For each second that you're off the chest when you stop, you keep going down. And then when you start, you don't go right back up to where you were at. You have to work your way back up. And so the problem with some of these studies is that how quickly were they putting on the Lucas to get this high quality CPR? Were there any hiccups in getting that on? Did they wait 30 seconds and then all of a sudden they're at the bottom and they can't work their way back up? And so in my mind, I'm a big fan of the Lucas, but you have to train with it and you have to be very, very, very proficient with this. So one person's doing CPR, the other one's getting the backboard. They're counting to 3, they're rolling to the side during a pulse check, they're rolling the patient over, and they're slamming it in and getting it started all in under 10 seconds. And then they're confirming that there's a good pulse with the Lucas going. To me, this is a lifesaver. You think about it, a lot of the problems with a lot of our data is the fact that, and we'll get into it a little later, when you're in the middle of a house and you're on the second floor and you're doing CPR, if you're doing manual CPR, you can't move that patient. There's no way, right? You can't do compressions while you're going down steps. They're not going to be great compressions. It's even harder to do compressions when you're screaming down the road, turning left, right, hitting a pothole. Those aren't great compressions, right? This kind of helps with some of that in my mind. This kind of limits all those errors you can have. And so to summarize that, the biggest takeaway from person number 1 here is high quality CPR. In my mind, whether it's mechanical or manual, just make sure you're minimizing the stoppage and utilize your pit crew CPR and train. Cool. Any questions so far? Now we talk about person 3 here. So the person that's at the head of the bed is sitting here working on the airway, right? So we started CPR. We got the Lucas going, or we're doing manual CPR. Now we're kind of looking at some of the airway stuff. You really have a couple different options here. You could intubate the patient. You could throw in a supraglottic airway. You can do LMA, King, or you can just bag. You can do nasal cannula. I think any of those, honestly, are fine as long as you do it very well. So you can do the bag valve mask. This is going to be fast. There's no interruptions in CPR. You really don't need that much equipment. It requires a very good seal, so it's difficult in some of our Alabama-sized patients or patients with a big beard. There is a risk for aspiration. For your supraglottic airway, you can just push that thing right in. Very high success rate, minimal training. There's less airway protection, but there is a potential for air leak with these, but less so than your bag valve mask. And then your endotracheal intubation is really skill dependent. If you do this a lot and you can get it in and you're very confident in your skills, I think this is great. There are some interruptions in CPR, and depending on how big your team is, you might not be fully prepared for this intubation. You might get it in, but then don't have the bag laying around somewhere, or you might have a great view and then you can't get it and you're reaching for the bougie. It just requires a little bit more hands-on. There's a couple studies I looked at for this. Again, I did a lot of review because I'm going to this Resuscitation Academy at the end of the month. So I wanted to make sure I was prepared. But there's the part, the airways too, the CAM, and then I threw in the Japan registry just because they had a huge amount of people that they put in it, and I just thought it was interesting. But the part study in 2018 looked at the laryngeal tube, the supraglottic airway versus intubation, 3,000 patient And essentially it said that the supraglottic airway, so your LMA or your King, improved early survival versus the Airways tube, which looked at the iGel for the supraglottic airway versus the ET tube, about 9,000 patients, and showed that there was no difference. So no difference between something I can get in fast, very quickly, easily versus intubation. The CAM looked at intubation versus bagging the patient, and there was no survival difference. So a lot of these studies essentially said, why are we intubating in the field? And some of these people said that EMS should not be intubating in the field whatsoever. I completely disagree with that. I think we should have the ability to do each three and to think through it correctly in the field and make a decision based on the patient in front of us. And so we're going to do a little bit of thinking when we're out there in the field and we're having to do an airway. So first things first, for this patient at the head of the bed, they're going to put this patient on nasal cannula. They're going to crank it up as high as possible. We're going to get some passive oxygen this way, and it will give us a little bit more time. Even if it's just a little bit, it gives us a little bit more time. Then they're probably going to start bagging the patient. And then they have a decision in my mind. Are they going to put the supraglottic airway in, or are they going to intubate the patient? So I wanted to go through a couple cases kind of looking at this. You can imagine you're a two-person ALS crew responding to a witness cardiac arrest. 62-year-old male collapsed while mowing the lawn. One person applying defibrillator pads. One person begins compressions. So you're very limited in the resources you have right here. This 62-year-old male, whenever I hear mowing lawn collapse, I'm thinking cardiac, so I'm thinking he might have a heart attack. I'm thinking this might have been a VFib arrest. So I'm putting the pads on. We're doing compressions. You have a decision with the airway. And so in my mind, in this 62-year-old male, we have two people here. We're probably going to place a supraglottic airway. So we're going to do nasal cannula, high flow, maybe bag, and then we're going to put a supraglottic airway in. Why? Because that is going to be quick, high success rate, and it's going to be easy for our two people there. We're going to minimize the interruptions for compressions, and we're going to free hands for pit crew CPR tasks. So if someone can get an IV, we can drill a shoulder. Now, if someone else gets there, if a crew comes there for backup, sure, we can go ahead and intubate the patient, but I want to make sure that that crew there with the limited resources puts in that supraglottic airway, gets that airway immediately, and can move on. Case 2, 54-year-old male found down in restroom bathroom. CPR begins, patient's actively vomiting, large amount of gastric contents. You're suctioning out a lot. No matter what you do, it just feels like each compression's pushing up more and more. We've all seen these type of cases, right? And so you're doing high quality chest compressions, you put the nasal cannula in, you're getting access, you put the pads on. Well, now we have another airway decision in this case. And I hope you see how this is a little different than the first one, right? So I am suctioning. If I put that supraglottic airway in, if I'm bagging, I'm putting him at a high risk for aspirating. And so my decision here is he's high risk of aspiration, poor ventilation, airway obstruction. And so after quality CPR, I get the access. I'm probably going to fight for a definitive airway, and I'm going to intubate this patient. But I'm making sure I have everything set up. This isn't something I'm going to rush into. I'm making sure I have suction. I'm making sure I have bougie. I'm making sure I have everything I need to get this airway, because this is very important. For case 3, you have a 35-year-old male, collapses at a gym, witnessed arrest, bystander CPR, initial rhythm was VFib. By the time you got there, they did this so well that this patient has a heartbeat. The problem is you go up to him and his jaw is just extremely locked. He's biting down. Nothing is going to open his jaw. And so your airway decision here, you start panicking, not panicking, but you start like getting a little puckering. His oxygen sats start dropping. You're like, oh, well, he's about to rest again. And so you can't place an OPA. You can't place a supraglottic airway because he's biting down so much. You could do an NPA. Absolutely. You can do an NPA and then you start bagging. But this is one of those decisions where I think RSI would be appropriate. Okay, so this patient needs to be relaxed. The jaw needs to open. So if you push paralytics at this point in time, you can get more access to the mouth and you can ventilate and oxygenate this patient better. So I hope you see like each one of these cases have different nuances, just like each one of the patients you're going to run on are going to have different nuances. I don't think the answer is every patient should be intubated. I don't think the answer is every patient should have a supraglottic airway. I think we need to think through some of these cases and determine what the patient needs based off of what's in front of us. I think that's the correct answer here. It's just kind of a little summary. Supraglottic airway is fast, hands-free. Tube's going to do your definitive airway. RSI, someone's gut clenched. And then bag valve mass is not inferior to everything else. So if you can't do anything else and you can bag them, you're going to be just fine. All right. So while I'm looking through all this, and you start realizing that you can't save them all, but you can do what's best for the individual patient, which is kind of what we've talked about a little bit, especially with airway just now. Back in, I believe, 2020, there's a couple studies that came out. And before I get into some of these studies, I want to like hand up and admit something. I am biased. So I am an emergency medicine physician. I have no background in EMS, right? So I have been trained through medical school, through residency, and now the emergency department. I lean, whether I like it or not, for the hospital, right? I love the hospital. That's where I work. Now, I just want to say that. And I also want to say I'm on your side because I like what you do and I like helping you. And so I'm looking into all this resuscitation evidence because I'm going to the academy at the end of the month. There's a couple studies like this one, Berry et al., that looked at high rates of field determination or field termination of resuscitation and longer scene times that also have high rates of, I guess, ROSC, survival. And so I believe this was back in like 2020, 2018, maybe even for 2018. This is essentially saying that we have better success in the field in getting ROSC on these patients if we stay on the scene longer. That makes sense? So this is kind of where it shifted from the whole load and go, scoop and run theme to stay in play, work on the field, in the field. There's another paper that was released around the same time. It looked at intra-arrest transport or continued on-scene resuscitation. And again, this found that there's better neurological outcomes if we stay in the field and we work these patients. You might be, what about the VFib versus asystole versus PEA? These studies, it didn't matter. So if the patient's asystolic, if they're in PEA, if you work them in the field longer, they have better outcomes. There's more survivors and there's more functional neurological survivors at the end. So the best overall evidence is that intra-arrest transport is usually associated with worse outcomes on scene resuscitation. And I believe why looking at this is because CPR degrades as we transport the patient. We've kind of talked about it, getting them out of the house, getting them in the back of an ambulance. And there's also something, you know, me and Chief Ward have talked about, there's something spiritual about this. I don't know where you lean on all that, but when there's a dead body there, there's just something about it that we don't understand where moving this patient is going to affect what's going to happen. Don't know about it, but I'm sure we've all seen it where like just something about it, when you move that patient, I don't know if it releases hormones, enzymes or what, but moving that patient during that time, that body just completely shuts down. And so there's something about it. And I mentioned that I fight for the hospital because in my mind, when I've gone on these runs with you guys this year, we do everything great and we work, and we get to like minute 10, minute 12. So we've been around 3 rounds of CPR. We've been doing high quality compressions. We've intubated the patient. We got a IO or we got access. We're giving all the meds possible. And now I'm like, we need to go to the hospital because that's where I'm comfortable and that's where I think. And the reason I want to just share with you, the reason I think this is because there's things that we can fix in the field. So we can fix oxygen, we can fix glucose, we can fix if their potassium's a little high. Things we can't fix is going to be electrical storm, PEA, bleeding. Do they have fluid around their heart and they need a pericardiocentesis? Do they have a PE? Do they have a heart attack? Do they need to go to the cath lab? Do we need to give them lytics? Or do they have a head bleed? These are things we can't fix in the field. And so in the hospital, and this might change over time, I can do an ultrasound. I can look at the heart. I can look at the lungs. I can do arterial lines and look for what's called pseudo PEA essentially, or pulseless. It's like press and prim and press. I can get labs and see if they're hyperkalemic or hypokalemic. I can look at multiple dysrhythmics for their electrical storm. I can do targeted temperature management if they're hypothermic. I can get them to the cath lab. If they're young and healthy, I can call the ECMO team to evaluate to see if this is an ECMO candidate. I can do a pericardiocentesis, and again, I can do the lytics. So in my mind, I think there's a happy medium here, right? So the data right now is showing that we need to stay in the field and work these patients. But also in my mind, I'm like, there's some things that I think we need to go for. And so for these patients that you run on, I think we need to just think through this a little bit. As an early intern in residency, cardiac resuscitation, cardiac arrest really made me nervous. And then over the next year or so, I really started dumbing it down, just to be honest with you, right? Like compressions, airway, timely shock, epi, right? That's it. Pretty easy. That's not stressful at all. I could do those 4 things and remember those 4 things. And now the more time I've been out, the more time I've spent with you, I think we need to think a little bit more on these. We need to think. We need to consider each outcome and what would be best for the patient in this situation. So if we go back to our case, our difficulty breathing, you successfully determined that this patient was in cardiac arrest. You have practiced your CPR, your pit crew CPR. You've considered the fact that this patient, by the time you get there, is probably in asystole or PEA, but there's a chance that they're in VFib, VTAC. So we need to quickly put the pads on them and defibrillate them if need them. I wanted to talk through a couple cases, and then I've left plenty of time because I was hoping to talk through it with everyone. But if you can imagine, you get there, this patient that we just ran on, difficulty breathing, we've done high quality CPR with minimal interruptions. I don't care if it's mechanical or manual, just do it well. We've done the nasal cannula, we've done the back valve mask. I don't care if it's supraglottic airway or intubation, just do it well, do it intentionally. We've done timely epi with access. Now, as we're sitting there, we've done all these things very successfully. We take a step back and we start taking in all the data. So what is their age? What is their comorbidities? What is their history? We start going through our H's and T's. I think we've gone away from really going through those. So we go through our H and T's and we realize that this is a 35-year-old female with a clotting disorder and had arrest right in front of family. You get a little bit more history. Maybe she hasn't been taking her blood thinner. She's been out of town. She ran out. This patient could have a pulmonary embolism. Nothing you're going to do in the field is going to fix this pulmonary embolism that caused her to arrest. But if you get her to the hospital, I can maybe give her a lytic to kind of chew through that blood clot to get that blood circulating a little bit more. So maybe this is a patient that after we've done everything successfully, we can get her to the field. Here's my other one. Yeah, now this guy, excuse me. So if we imagine we go back on that case, difficulty breathing, what am I missing here? See, this is where I need my notes. They are quiet. Yeah, so this guy, if you can imagine, you get dispatched on a difficulty breathing, you get there, you find him to be in VFib, VTAC, you do the timely defibrillation, you're defibrillating, you get the timely access, you do the nasal cannula, back valve mask, supraglottic airway versus intubation, Now we've taken a step back again. We look at age, comorbidities, history, and it's 58-year-old male, diabetes, hypertension, chest pain, probably had a heart attack. Okay. The difference in this case right here is that this patient, if he had a heart attack, he's not going to be taken to the cath lab until we get a pulse back. And so the data would probably say that the best thing to do is to stay in the field and to resuscitate this patient. Now, if you're shocking multiple times, you're probably going to have to transport them, to get the electrical storm taken care of. So just to summarize so far everything I've talked about, anticipate the worst when you're dispatched, train with one another to become excellent at CPR, minimize time off the chest, use judgment for airway decisions, and overall ask questions. Ask questions now. I'm about to stop. I hope you ask questions. Follow protocols and your medical director input. All right. I know that was quick, but I was hoping we had some discussions online.
Well, we haven't had anybody ask anything online, but I have things to say, Dr. Kirby.
I want this. I want discussion.
Yeah, so the first thing I have to say is thanks for a great lecture. Very well presented. Love the evidence. And I think everything you said is right on. The big problem we have is a little bit, me, it's more problems of culture than it is problems of medicine. I think you did a good job explaining your point of view as a physician. You want the patients in the hospital.
Oh, I know that. Yeah, for sure. Yeah.
I want to work resuscitation on the scene,
Yep.
and I have a bias towards that. It just so happens that I'm right. No, I think there is a way, there are patients that do better probably with extended resuscitations, and we have documented cases of resuscitations for over an hour in this area who survived without any neurological damage. We also have cases that were unsuccessful, a lot of cases that were unsuccessful, and we don't know what the opportunity cost of staying was. Would they have survived if we would have transported earlier?
And there's no way to find out, by the way.
We're going to be able to research that and find out.
Because we're not going to put people out in the field onto two study arms and be like, this patient we're going to take to the hospital, this patient we're going to leave here.
Actually, that Greenough study kind of did that you mentioned. So
they did, yeah.
The part of that you didn't mention is they had a hard timeline. 25 minutes on the scene or longer is almost a 13% survival rate.
Right.
Less than 25 minutes was less than a 3% survival rate. To me, that's the strongest argument for us to stay on the scene.
Yeah.
And I don't know, it's a cultural thing. It's, do we get comfortable being on the scene? I've been involved in agencies where that crews did get comfortable staying on the scene for a long period of time. I think that we have to not just sit around and talk about who's doing what. I think we have to physically train regularly to get good at it. It's not just a talk through. No matter how many times your crew's done it, you got to get the dummy out, you got to get the equipment out, and not just once or twice a year, but at least every month, for this to become a reality. And so I think that's a big challenge for most moderate to very busy fire departments. I think we can all recognize that that's a big ask. I think it's a bigger ask for EMS folks to really come to a determination what caused their arrest on the scene.
Yeah, no, I completely agree with that, right? Yeah. And there's a happy medium here, and I haven't landed on it,
Yep.
But yeah, asking the people out in the field in those stressful situations with Meemaw, right beside you crying and screaming, and then you have dogs barking in the other room, to ask you to consider these other things is a huge ask. It is. Yep. I recognize that.
So a couple of little minor things I just want to mention. On one of your slides, you said that ventilating with a bag valve mask intubating might interrupt compressions. I would suggest that if you have to interrupt compressions to intubate, then you should never intubate.
Yeah.
Just don't interrupt compressions to intubate. The other thing I would point out about that is if the patient has vomit in their mouth, you shouldn't be ventilating them. You should be getting them suctioned and having an advanced airway.
Mm-hmm.
Doesn't do any good to ventilate a patient when they have vomit that's going to go into the glottic opening when you pressurize it.
Yeah.
That's actively working against it. So, I mean, to me, that's got to be part of the decision for an advanced airway.
Right. And that was kind of my point, that they're vomiting a lot. Of course, you're going to suction, you're going to do the nasal cannula and everything, but this might be a patient that you need to get the ET tube in versus a supraglottic or even bag valve mask.
Right.
You just need that. You need that hole closed.
Yes. I would also suggest, you showed some data about accuracy of dispatch complaint. And Chief and I actually participated in a study from trauma patients, and we found that dispatch complaint was far less accurate than what that study showed on actual complaint, didn't we, Chief? And it was he and I that were deciding based on dispatch data in real time what kind of patient we were going to. It wasn't about cardiac arrest. It was about
Right.
major mechanism of injury trauma patients. We were closer to 30% accuracy on dispatch complaint. And so I want y'all to think about that, because we all know it. If I asked everybody that was listening, hey, is a dispatch complaint often incorrect? Everybody would say, yeah, they're wrong all the time. But then we continue to make operational decisions based on the dispatch complaint. We get dispatched to fall from standing, and we take in a couple of things: the stretcher, the laptop, maybe a C collar, right? And oftentimes fall from standing is cardiac arrest. My point to that is the only reasonable thing to do is to take all the equipment you need to work cardiac arrest to every patient. And people go, oh, that's so much work, we don't need it 99% of the time. That's right, you're not going to need it 99% of the time, so you carry it back. It's really not that much work. Everybody has two pieces of equipment in their hand. You got plenty of hands. We just don't want to do it because it feels like unnecessary labor. It's a culture issue more than it's a data issue or a medical issue.
And
I would
think
challenge you to arrive at every patient's side prepared for medical cardiac.
Yeah, and I think that's a good point. I think that's kind of what I was trying to get at, is the fact that, you're dispatched on this difficulty breathing. 911 dispatch gets it right, I believe, some of the time, most of the time, but sometimes they're wrong, and they're dealing with a lot. It's not their fault. But as you guys need to anticipate the worst, and so like you're saying, just carry the equipment with you.
Just carry the equipment.
Just carry the equipment. Be prepared.
Yeah, and you also got to remember that patients change between the time they call 911 and you get there as well. And there's also a joke in the hospital, right? So for the docs here, you know that the med student goes in and evaluates the patient, comes out, tells you the story. The resident goes in, that story changes 100%. And when the attending goes in, the story changes the third time. So, I mean, you don't know what you have until you physically assess and determine what's going on with that patient. The other cool thing I want to say, like you said, is we can't lump all cardiac arrest into one bucket. People die from different things, right? But I think the priorities of care, like Dr. Kirby said, are super important. Early recognition of sick or not sick, early intervention of chest compressions, good airway management. And the way you manage that airway is also have your airway equipment, like Chief said, readily available. If it's 3 layers down in your bag and you can't get to it for 3 or 4 minutes, you got a problem. You got to have your suction available, and you got to look at each patient individually, working where you find them. And when you're able to do that every time with complete efficiency, then you can start thinking, okay, what actually caused this? Oh, this was that STEMIA patient arrest that's been in VFib 6 times. Maybe I do need to pick up and move toward the hospital so we can lyse them. Or maybe it's that patient that needs ECMO. We're starting to do ECMO at UAB again as well. But there are some considerations and time constraints. But if you can't do the basic resuscitation, which really isn't that basic, there's no reason to move forward with anything else.
Yeah. I think the Lucas device or the mechanical CPR devices kind of limit those complications of moving the patient if you do it well and you're intentional about the movement. But I will say that the data says stay and work the patient.
That is a perfect segue to my question, because you presented 2 studies here, this Grinnell study and the one before it, the Bernard study, that talk specifically about stay and play versus load and go. Now, some of us are old enough in this room to remember when this changed. And both of these studies were actually done prior to the widespread adoption of mechanical CPR devices. So I'm going to put you on the spot and say,
what year was that?
Widespread use. So the Lucas 2 device was in 2014.
Right.
The data collection on the previous study, the Bernard study, began in 2013. So before the widespread use of Lucas in the US.
Mm-hmm.
So These are manual CPR where that they were comparing on scene, stay and play versus load and go.
Interesting. So
With the widespread adoption of Lucas, in your opinion, I'm putting you on the spot. Do you think this changes our management and what we should be doing in the field?
putting me on the spot. I am going to say, I'm going to put my foot down. So the question is the studies that say staying on scene is better than loading and going, was more beneficial for the patients than getting them there. That studies were done after the Lucas devices or manual or mechanical compression devices. I'm going to put my foot down and I'm going to say that to me at this time, knowing that information, I say that doesn't change anything in my mind. And the reason being is because if most of your calls are going to be asystole or PEA, I think the things that we can change in the hospital, majority of them are we're going to be finding that it's not actually PEA, it's fine VFib with an ultrasound, or it's not, or it's VFib and we need to lyse them. I think that wouldn't change anything. I would love a study to show that it's different before it changes for me.
I would submit that staying on the scene has a lot more to do than just physiology.
Yeah, we talked about it. Yeah, we've talked about the whole.
I think that when you stay on the scene, it gives the crews a chance to think through the resuscitation.
Right.
It gives a more relaxed environment when you don't feel the pressure of transporting immediately, so that the patient receives better basic care. And that's what I've observed in my career. To snatch them, throw them, apply high flow diesel fuel is chaotic. Nothing that's done for the patient is done very well. When you stay and you commit to staying on the scene, I would also suggest that we use end-tidal capnography during cardiac arrest to help us decide how long we should stay on the scene. I think that anything, when good chest pressure is going on, where you find an ETCO2 that drops below 15, I think that's a patient that's not going to survive. That's a strong indicator. There's some data that backs up that statement. And I think that we should use that objective data as much as possible in our operational decisions.
Can I push back a little bit on that comment and just play like flip side?
Yep.
So your argument is that we need to stay in the field to do everything successfully, right? Do everything well. Why can't we do everything well within the first 5-8 minutes? Because after that, once we get access, we got the machine rolling, we've intubated.
Because the time that I see crews really communicating effectively with each other and really optimizing care is when you reach that steady state point where there's nothing pressing to do next. That happens.
Oh yeah.
5
Oh
to
yeah.
10 minutes.
That's the best times in the hospital. I love it. You're having a rest in the hospital and it's silent. That's why I like emergency medicine so much. I like fighting for order and chaos. And there's not much more chaotic than a code or a traumatic arrest.
Yeah, and I think it's when you get that release of the time pressures, when people can see things that without the pressure are obvious, but with the time pressure, people can't think about it. Like, hey, how come we don't have a waveform on the capnography anymore? Oh, the tube's dislodged.
Yeah, they have a second to think.
Hey, what's the
step
rate
back
of our
and think.
ventilation? Why are we ventilating at 30 times a minute? Slow your ventilations down.
Yeah.
Hey, is the position on that Lucas device correct? Do we need to pause for a couple of seconds and reposition it? You don't have that if you're trying to get to the hospital when you're trying to limit the scene time.
Yeah. What, you got a question, man?
Studies of like 25 minutes showing greater outcomes. But for traumatic arrest, would you also recommend doing the 20-25? I know the survival rate is a lot lower.
Yeah, everything we're talking about
no,
today
this is-
really applies to
yeah.
medical cardiac arrest.
Yeah.
So I pose this question. Why do we say it only applies to medical and not trauma? What's the difference?
Surgery.
Yeah, sometimes you need things that you can't provide in the field. So like you were saying earlier, sometimes there are patients you can pick up that the only intervention that's going to make a difference is something at the hospital, such as a big PE and a lytic or something. But again, I think that the great discussion, guys, super appreciate. This is some good talks. But, remember that if someone is not breathing, doesn't have a pulse, you only got a few minutes to get things going. We got to manage them on the scene where we find them. And when we can do that efficiently, then we can decide, do they go to the hospital or not? Right? So, great. Chief, we got time for one more question, you think, or?
Well, we got some folks that have been typing online here.
Uh-oh. You want my glasses?
85% of Alabama is volunteer fire department. So I would say 85% of the geography of Alabama may be volunteer fire department, but 85% of the patients are not treated by volunteer fire department. Any specific BLS advice beyond high quality CPR?
Yeah, I mean, yeah, you're not gonna be able to transport those if you don't have a transporting agency, and it's the primary things, good airway management, providing oxygen, adequate ventilation, early defibrillation with the AED or whatever you have, BLS, and then hoping that ALS transport gets there. You can rescue someone from a VTAC, VFib arrest with chest compressions and an AED. So the basics, which are not that basic, are super important. You're right.
Yeah.
Yeah,
Go ahead. No, I would say that for those, you have to know how to work your AED. Like that's hands down. You have to know what it's going to prompt you to do. You have to know what you're looking for, because I've seen a couple cases where they didn't know how to work the AED.
So we've got some other folks here commenting about post arrest care and the value of making sure that you don't snatch and grab after you get ROSC.
Yeah.
Essentially, if I can kind of summarize what I'm seeing online.
Oh, as far as like, we've
Yeah.
gotten ROSC now, like let's
So,
slow down,
yeah.
run a blood pressure, get an EKG, make sure they're resuscitated.
Many of these people have probably heard me talk on the subject before, and I always emphasize, have a plan before you move the patient. Don't get the patient up on a backboard and then decide you have to move furniture out of the way. When they get ROSC, leave them there, get your 12 lead, stabilize their blood pressure, push those epis great. There's other options as well. Make sure that your ventilation's good, because what happens to patients post-ROSC all the time? They rearrest.
Mhm.
So be in a position where you're prepared to begin resuscitation again. You want to move them from wherever they are to the transport unit. You don't want them to rearrest during whatever period of time that is, right? Because now you're stuck. You're in transit. You're going down steps. You're whatever. So leave the Lucas detached. You can, if you have a Lucas, bring the suction cup up. That way, if they rearrest, you can push it back down, hit play again. At least we're getting chest compressions going. I would say once you commit to taking them from where they are to the transport unit, in most circumstances, cardiac arrest in Alabama happen in a residence. In most circumstances, the transport unit is parked on the street. So I would say if that's the situation, I would commit once I move them to getting all the way to the transport unit and then immediately reassess, because something probably went wrong during that couple of minutes. Tube got dislodged, IV gets pulled out. Everybody that's done a cardiac arrest in the field understands all those issues. So it's really important to stop, reassess before you take off the hospital. And then take enough people with you. If you're a fire-based EMS and you got an engine and a rescue unit, take one or two or however many you can, the engine with you. That's the most thing. We've done all this work to get a successful resuscitation. Let's make sure we get them to the hospital in the best possible physiological condition. So we got a great thing going here today. I think we've got 4 physicians in the room, maybe more, and not just 4 physicians, but 4 physicians that are all in various ways leaders in the state, not only in emergency medicine, but in EMS. And so one of the challenges I have for you physicians is, what can we do about the culture in the hospital? Because we all get frustrated when we bring cardiac arrest or post-arrest or ROSC patients to the hospital, because based on what we do in the field, there seems to be very little resuscitative effort in most emergency departments. They give up pretty fast. I think it's a cultural issue, and I think it's because there's not a lot of success in that environment. And all of us look to the hospital staff as to how we're supposed to behave, especially the younger folks in the profession, and particularly the students doing rotation. They see a cardiac arrest resuscitation in the hospital. That's their ideal that they try to emulate when they get to the field. From what I see, it's oftentimes not that great and very short.
I think that's a very good point. And thank you for that. You know, there's so many times people come in, they've been worked in the field, and we immediately just put an ultrasound on and call it. Like, if you want a culture change, it starts there with us, making sure that room is set up, taking this seriously. We take our time. We make sure everything's done that we can possibly do. At least we've considered it. I'm definitely going to change that. Thank you for that. That was good. That was good.
Yeah. Another reason that you work them where you find them, you give that person the best chance to survive with your hands, so that way your conscience is clear with those kind of things. So.
And help me welcome former paramedic in the Birmingham area and great friend of EMS and great friend, period, Dr. Cohen is going to talk to us about endocrine emergencies.
Yep. So yeah, I'm Cal Cohen. I'm a second year emergency medicine resident at UAB. I did EMS for quite some time before I went to medical school. So I can relate to all you guys. I know most of you guys in the room, maybe taught most of you in the room at some point. So we're talking about some endocrine emergencies. I have no disclosures because I make no money. Nobody pays me to do any of this. So I'm broke. So we're going to talk about some cases here. So case one, you got a 21-year-old guy called because he's altered and agitated. Rummaging through the house looking for something, can't really tell you what it is. He's shirtless and sweaty. So what are you guys thinking? Outside of being an endocrine lecturer, what are you thinking? Sure. So it's probably drugs, right? I mean, he's young, he's sweaty, he's confused. It's probably drugs. So mom comes in, calms down a little bit, says he's diabetic, just diagnosed, started some medicines, doesn't know what it is though. He's never done this before. He's a great kid, doesn't do drugs. Does that change your thoughts? No, it's probably still drugs, right? Or maybe it's this kind of sugar. Maybe. We'll see. Case number two, a 54-year-old guy. He's confused. He's sweaty, tachycardic. He's only alert, oriented to himself. And he starts getting pissed off at you when you ask him questions. What do you think? Maybe sugar? Maybe. Or maybe it's drugs? All the above, right? So his wife comes in, history of AFib, had AFib for a long time, high blood pressure, heart disease, started some amiodarone for AFib with RVR because it wasn't responding to the other meds. So maybe it's these kind of drugs, right? Potentially. And then case three, and we'll kind of go through these as we go through the lecture. 64-year-old female, call for general illness. You get there, she's lethargic, confused, pale, looks very ill. Said it was going on for about 4 days. She's tachycardic, hypotensive. What do you think? Maybe. History of rheumatoid arthritis, takes steroids daily, had the flu, diagnosed 4 days ago. Maybe it's something endocrine. Maybe. So the endocrine system is this big network of glands. You have the hypothalamus pituitary axis that kind of drives everything. But your big organs or glands are your thyroid, the adrenal glands, and the pancreas. We're not going to talk about the ovaries and testes. That's a different lecture for a different day. But we're going to talk about diabetic emergencies, thyroid emergencies, and some adrenal emergencies. Diabetes is kind of the most common endocrine condition in the U.S. I think there's like 1.25 million cases of diabetes every year, but it only accounts for, or hypoglycemia is the most common emergency with these. There's two types, type 1, type 2, and type 1 accounts for like 5% of all of your diabetic patients. And then there's some special considerations for each of these types of diabetes that we'll get into. So type 1, this is your insulin-dependent diabetes. So this is generally an autoimmune disorder where basically in the cells of the pancreas, you have the beta cells which secrete the insulin. And in type 1 diabetes, for some reason, those beta cells are destroyed, damaged, agitated. They don't produce insulin. So these patients require insulin to function. They have to give themselves insulin. And most of the time, these present early in life. So we call this like juvenile diabetes or early onset diabetes, something like that, because it's an autoimmune process. The body kind of destroys those cells. But you can have it present later in life as well with different autoimmune disorders. And then type 2 diabetes is insulin resistant. So this is the patient that has chronically elevated blood glucose, chronically elevated insulin levels, and the peripheral cells throughout the body kind of build up a tolerance to insulin and don't respond to insulin as well. So these patients will take insulin in higher doses to try and get the insulin to have effect on the cells, or take other different medications to make the cells respond to the insulin that they're supposed to. It's a complex metabolic disorder. As you can see, it affects all the cells in the body. So you can have all kinds of different complicating factors. So we'll talk about some meds. Type 1, the only medication is insulin, right? There's different formulations of insulin. You have rapid acting, which starts in like 5 minutes, but only lasts like 30 minutes. You have short acting, which has a fairly rapid onset, 5 to 10 minutes, and can last for an hour or so. Intermediate can last about 5 to 6 hours, and then long acting is going to be like a 24-hour kind of dosage. Generally, with the traditional management of type 1 diabetes is what they call a basal bolus insulin regimen. So you're going to do a basal of the long acting. So you usually do it at night and it lasts 24 hours. And then you have a bolus for any time you eat anything or you check your blood sugar, you're going to give yourself a bolus. So it's a pretty intense regimen, and somebody who's just starting with diabetes may have issues kind of figuring out how to do all that stuff. But then we have these insulin pumps. So this makes it a little bit easier. So it's an indwelling catheter that stays in the skin, and it continuously provides a basal bolus or a basal dose of short-acting insulin. And then it's usually paired with a continuous glucose monitor or CGM, and that in conjunction will provide the bolus so you don't have to input numbers and do math and adjust the dose as you need to. But these things can fail just like with any technology. So if you have a patient that has an insulin pump, the recommendation is to leave it alone. Like if they're hypoglycemic, don't turn it off, don't clamp it, just leave it alone, treat them like a regular hypoglycemic patient. If you stop it, they're so used to having insulin that if you stop it, you give them sugar, you can send them into DKA. So we don't want to do that. And then we have these new, basically no strings attached. This is called the Omnipod. So it's basically just 2 pods that go on the skin, and it pairs to a phone, and the phone kind of does everything. So it's a little bit easier, but again, still technology, it can still fail. So just be mindful of those things. Type 2 meds, there's all kinds of meds. The biggest one, most common one is metformin. It is the absolute worst drug of all of them, has the most side effects, and it's terrible. It doesn't really do a great job. But if you go to your doctor and your blood sugar is like 200 at one check, they're going to say, hey, you need some metformin. So the biggest side effects with metformin is GI upset. It causes a lot of diarrhea, a lot of nausea, vomiting. So if you've got somebody who just started taking metformin and they're having a lot of diarrhea, you can have a lot of volume loss, a lot of electrolyte issues that kind of go with that. But basically, the mechanism of metformin is it suppresses the production of glucose by the liver. So you're not automatically producing more glucose in response to insulin. You can also have some pretty significant lactic acidosis. It's a rare complication, but it can be a severe complication with prolonged metformin use. The other meds, sulfonylureas, end in the ide, like glyburide or lipizide. These are longer acting medicines, basically potentiates insulin secretion. So it can cause profound hypoglycemia in somebody who takes these meds and doesn't eat. So just be mindful of that. Your SGLT2s are your Flozin meds. This basically prevents the reuptake of glucose in the kidneys. So you're peeing out all the sugar. So it can cause a lot of dehydration because you're peeing out more sugar. It can also cause some pretty significant GU infections, yeast infections, bacterial infections, because there's so much sugar in the groin area. And then your glitazones are designed to improve insulin sensitivity. Biggest issue with these is it causes weight gain, edema, and heart failure. So just be mindful of those guys. And then we have the new folks that come in, the GLP-1s, GIPs. These potentiate insulin secretion. They also decrease glucagon secretion and slow gastric emptying, so you feel full longer. But the biggest issue with these is GI issues, nausea, vomiting, maybe some diarrhea, and then now everybody takes them for weight loss. So, what's your ozone? No? Okay. So the biggest issues with diabetes, hypoglycemia and hyperglycemia. Hyperglycemia in and of itself is not a huge issue, but when you get into DKA and hyperosmolar hyperglycemic state, those are your issues. So your pre-hospital assessment for anything is basically the same, right? So your ABC is level of consciousness, keep it basic, right? You assess a patient, you're going to do all these things every time. But remember that glucose is part of your vital signs, okay? Especially if you got somebody who's a little bit confused, agitated, whatever, make sure you get a glucose. And then try and get a history of medical history, diabetic history, what meds are they on, any new meds, have they eaten, any recent illnesses that may have potentiated this, are they pregnant, because pregnancy can cause diabetic issues as well. So just kind of be as thorough as you can with the history. So go back to our case. Got type 1 diabetic, altered mental status. He's alert but confused, agitated, mildly diaphoretic. He's protecting his airway. He's talking to you. Glucose is 42. Everything else is normal. What are we going to do for this guy? What are you thinking? Huh? Juice, sugar, something. Yeah. If he's talking to you, oral glucose is great, right? What else? Maybe get an IV, give him some fluid, give him some glucose fluid, right? What do you want to ask him though? What meds? Huh? When did he eat, right? Has he not eaten for a couple days, right? And then what meds is he on? That's a big part of this, right? If it's just insulin, if it's just metformin, it's great. We can usually fix those things. But if he's on glipizide, that kind of changes our trajectory. So hypoglycemia, most common emergency. Most doctors try and get tight glycemic control because it's going to prevent all of the downstream complications of diabetes. So retinopathy, kidney disease, heart disease, all those things that come with having chronically elevated glucose. In general, you can have somebody who is hypoglycemic with a glucose of less than 70, but it's all relative, right? So if you got somebody who's chronically at 300 and you check their sugar in 20, but they're confused, they're sweaty, they have all these adrenergic symptoms, they may still be slightly hypoglycemic, right? That's usually going to be in the type 2, and it's not as life-threatening as somebody who's a glucose of 40 and they're type 1, but you can still treat them kind of the same way, okay? Most patients that have diabetes will experience 1 to 2 episodes of mild hypoglycemia in a week, and they're going to recognize the symptoms. They're going to feel shaky, they're going to feel hungry, they're going to feel sweaty, and they're going to drink some juice, eat peanut butter crackers, whatever, and it's going to resolve on their own. And then 30% will have a severe episode of hypoglycemia at some point every year, okay? And remember that hypoglycemia is one of the great mimickers. It can look like anything, right? Strokes, seizures, TIAs, drugs, psychosis. It can look like all of it. So just be mindful of that. So our anti-hypoglycemics, oral glucose is great, but you can only give it to somebody who's talking to you, maintaining their airway, right? Is this like a eat and swallow medicine? Or is it like pack it in your gum and let it sit there for a minute? It's a pack it in your gum, let it sit there for a minute. It's oral glucose, it's not PO glucose. So just keep that in mind, right? Try and make them hold it in their mouth, let it absorb. That's where it works. Onset's about 20 to 30 minutes. And this is only like 15 grams of glucose. So it's not a whole lot of sugar. So make sure that once you get their sugar up, they eat something with some sustainable carbs, protein, things like that in it. Sugar also works, right? So if you don't have oral glucose, sugar packets or some orange juice, those are good too. IV dextrose. So D50 was the mainstay forever. I think we've kind of gotten away from D50. Y'all still carry D50? Yeah. y'all carry D10 as well? Yeah. So there's different options we have now, and I think that's a great advantage. D50 works well for the severely hypoglycemic. You need to get them up really quick, but it has downfalls. So it's 25 grams and 50 milliliters, and generally will raise the glucose 150 milligrams per deciliter after you give that 25 grams. Okay. It's fairly rapid, 2 to 3 minutes, but there are a lot of complications. If it gets into the tissues around the vessel, it can cause significant extravasation issues. It's very hyperosmolar, so it can cause a lot of tissue necrosis, tissue damage. And you can potentially cause compartment syndrome because it's going to pull in fluid around it. It's going to make that area swell even worse. So just be mindful of that. Make sure you got it in a good IV and it's flowing well. You can also have some rebound hypoglycemia because you're spiking their blood sugar so high, their body's going to produce more insulin and it's going to bring it back down more quickly. So this is a very temporary fix. Okay. Got to make sure that you give them some food to maintain their sugar. And then D10, I think this is the better option. So the concentration, 10%, is 10 grams per 100 mLs. Most people carry a 250 ml bag, so that's 25 grams of dextrose. It's just in 250 mLs rather than 50 mLs. Onset's about the same, 2 to 5 minutes. And it's less overshoot because you can even titrate it, right? So if you're just letting it flow and they get their sugar up, they're mentating, you can stop it. You don't have to give them the whole 250, right? So you can just give them the dose that works, prevents the overshoot and the rebound hypoglycemia. It's still short acting, but it has less complications because it's not as hyperosmolar as the D50 is. So if it extravasates into the tissue, it's not a huge deal. Some pediatric considerations. Little kids don't get D50, right? So it's a good thing that we're all carrying D10 because everybody can get D10. It's great. The goal dose for kids is going to be 0.5 mg per kg of dextrose. And the easiest way that I do it is like the rule of 50. So your dose in milliliters per kilo and the concentration should equal 50. So neonates, infants get D10 and it's 5 mLs per kilo. So 10 times 5 equals 50. Kids, you can give D25 and you're going to give 2 mLs per kilo, 25 times 2, 50. And then adolescents and up, you can give D50, 1 ml per kilo, or just 50. That's enough, right? So just an easy way to think about it. What if you don't have IV? What are we going to do? Glucagon, right? So we have glucagon. It mostly is an IM formulation. There are some that are IV. And the idea behind glucagon is that it releases stored glycogen from the liver to raise the glucose. If you have somebody who's emaciated, malnourished, a chronic liver patient, they're not going to have these glycogen stores, so it's not going to be as effective. Onset of it's about 15 to 30 minutes, so a little bit slower than giving IV dextrose, and the duration is about the same, so about 30 to 90 minutes. So it's still a short solution, right? And the problem with this is it's expensive, right? Anybody know how much one of these little red things of glucagon is? It's like $250. There you go. So I looked on Boundtree and it was like buy a case, $250 each. I was like, per case, yeah. So it was like $1,000 per case, but each one is $250. Anybody know how much D10 is? It's like $20. So it's much cheaper and it's effective. But the only question is, do you have an IV, right? And then the other thing is, what if you don't have an IV? Can you drill them? You can, but in the state protocols, it says all uses of IO will be reviewed by the Office of EMS. So just be mindful. If you drill somebody to give them glucose, it's going to get reviewed. Try other means necessary, get IV, try something, okay? This is going to be your patient that's an extremist, though. You don't have other options, right? So this is your renal patient that has no IV access. You can't use the right arm because it's got a graft in it. This is your last option, right? And they can't refuse transport. You put a needle in a bone, they're going to the hospital. End of discussion. And there are some inherent risks of doing this. Your diabetic patients are going to have low or reduced wound healing, so you could cause more problems. They're going to have delayed healing of the bone, delayed healing of the skin around the bone, so it's going to cause issues. And if you're going to do this, I would say give D10 over D50, just because it's less irritating to the bone, may not cause as many side effects like D50 would. I saw Ferguson put on his microphone. Okay, all right. So go back to the case. We gave him some sugar. They don't want to go. Now what? What do you want to ask him? What are the big considerations? Does he have to go to the hospital? No. But what do you want to know? Yeah. Can you eat something? What else? Has it happened before? Okay. And again, the biggest thing is what meds are you on? Right? So the hypoglycemic treat and release, there's no state protocol for treat and release or treating on scene. There may be some in the future with current legislation, but as of right now, there is no state-specific protocol. There are some studies that show it to be effective, works well. We know it works well. But the National Association of State EMS Offices has their national model guidelines that come out every few years. The last one is 2022, and this is essentially the disposition part. It's like a 3-page section on hypoglycemia, but this is what really matters. So if they have hypoglycemia, continued symptoms, they go to the hospital, right? If they've had a seizure, they should go regardless of their mental status, because we don't know if it's like a hypoglycemic seizure or if it's a seizure and then hypoglycemia after. So seizures should go. But if all of these are true, then you can treat them and they can stay at home, stay wherever they are. Repeat glucose has to be at least 80. They take only insulin or metformin because those are the short-acting things, right? We can fix those. If they're taking something long-acting like a sulfonylurea, that's probably going to require monitoring fluid drips for a long period of time to make sure everything stays stable. So only insulin, only metformin. They have to return to their mental status baseline with no focal deficits. They can obtain and eat carbohydrate meal. Either the patient or the guardian can refuse. Reliable adult on scene, staying with the patient. No major comorbid risk factors like chest pain or shortness of breath, anything like that. And you have to know kind of what caused it, right? So what do we do if we want to make sure that they're okay to stay home? It's peanut butter jelly time. Go make them a peanut butter and jelly sandwich. Make sure they eat it, right? I have made many peanut butter and jelly sandwiches at 2 o'clock in the morning. So peanut butter jelly time. So they give this guy 250 of D10. He's awake, he's alert, not sure why anybody's there. Ultimately, he has no other symptoms. Bloodborne, go to the hospital. Okay with that? He had a peanut butter and jelly. Yeah. So your hypoglycemic summary, if they're altered, check glucose, ask about meds, ask about weight loss meds, try to figure out why their sugar dropped, have a backup plan if you don't have IV access, and then kind of understand your treat and release guidelines, have a plan for what you're doing next. The flip side of hyperglycemia now, generally a glucose of greater than 250. Hyperglycemia in and of itself is not a huge issue, but with other signs and symptoms of DKA, it is. So DKA patients have a mortality of about 3% in the US, but about 40% worldwide. So DKA is a big issue. These patients go to the ICU, okay? They're going to present, or DKA is a relative insulin deficiency. Basically, your cells are all starving. So that even though the glucose may be high, the cells can't use that glucose, right? So insulin is the key to all of your cells using the glucose. When this happens, your cells kind of send signals. The liver says, hey, let me help you. Let me produce some more sugar, so the sugar gets higher. Insulin doesn't change, right? So then your body starts using free fatty acids to metabolize, and that goes into bodies. You have acetoacetate, acetone. Those are all like substrates that the cells could potentially use, but there's still no insulin, so they can't use it. So now you've got all these things floating in your body, and it become acidotic. And then you have hyperglycemia, which is going to cause osmotic diuresis. They're going to pee a ton. They're going to be concentrated. And then the ketones are going to cause acidosis. You can cause some myocardial depression, some vasodilation, and then you're going to have the compensatory hyperpnea or Kussmaul's respirations, right? The very deep, very rapid breathing. Anybody ever seen that before? It's very weird. Just a little thing. If you've got somebody who's in DKA, try and not intubate them because you're not going to keep up with their minute ventilation. Okay. So DKA is kind of a conglomerate of things. You have to have the D, the K, and the A for it to be DKA. But you guys can't really assess the K and the A, right? All you guys in the field can know that it's hyperglycemia, but you can see kind of the presenting symptoms, the confusion, the hyperpnea, things like that. If you can smell ketones, if you're one of those special people in the world that can smell ketones on the breath, it's great for you. I cannot. But there's some physicians in the ER that can walk by a room and say that person's got DKA, which is the weirdest thing in the world. But they say it smells like acetone. I still can't smell it. But usually there's some sort of precipitating stressor, infection, MI, trauma, or pregnancy that's going to tip a diabetic patient over into DKA. The presentation is generally non-specific at first. They may just have kind of some abdominal pain, some nausea, some vomiting, and then it kind of progresses to some tachypnea, tachycardia, fatigue, some altered mental status. They're going to have some dehydration. But at first, the thing is it's non-specific, right? So you got a patient that's just got nausea, vomiting. You check their sugar and it's 350. You might thinking this is early DKA. Okay. The biggest issue with a lot of this is they're dehydrated. Okay. DKA patient may be like 2 or 3 liters down. So start some fluids. That's fine. But in a kid, if you suspect DKA, be mindful about not giving them a whole lot of fluids. Stick with your like 10 cc's per kilo over 30 minutes or so, because if you flood them with a lot of fluids, you can cause cerebral edema. We don't want to do that. Okay. So kids, a little bit of fluid, they need insulin more than anything. Okay. So like I said, these guys are sick, severely dehydrated, they're tachycardic, they're altered, may not be able to protect their airway. But again, if you can, do not intubate them. I know, RSI is coming out and it's progressing. If you take this patient's airway, you're not going to be able to compensate for them because they're breathing fast enough to compensate for themselves. So even our ventilators in the hospital can't keep up with a DKA patient. So be mindful of that. There's also going to be some significant abnormalities in their electrolytes. So make sure you put them on the monitor, keep them on the monitor, monitor for heart changes, because that's a big part as well. So DKA, they're sick, non-specific at first, can present with the classic, altered mental status and ketones and things like that. But it's a lack of insulin, cells are starved, ketosis, acidosis, dehydration, electrolyte issues. And then kind of the other more common in type 2 diabetes is this hyperosmolar hypoglycemic state. This is actually a more serious diabetic emergency than DKA, has a worse mortality of about 10 to 20%, and that's in the US, okay? The thing with DKA is it's usually a fairly quick onset, and you need to fix it fairly quickly. With HHS, it's usually an indolent onset, like 4 or 5 days, a week, and it kind of progresses that way, okay? They're going to be severely volume down. It's hard to tell a difference in the pre-hospital setting. The general consensus is that DKA is like a sugar of 250 to 500, but that's not always true, right? HHS is usually a sugar that's greater than 500. Most of your glucose monitors are just going to say high at 500. So you can have DKA at 550. You can have HHS at 450. So there's no rhyme or reason, no hard and fast rules for it. So just be mindful that high glucose, they're probably dehydrated. That's the biggest thing. And like DKA, these patients are severely fluid down, like 8-10 liters down. But you're not going to fix it all at once. It didn't happen all at once. Not going to fix it all at once. So they're going to come in the hospital, be fixed over days. Your pediatric considerations for the hyperglycemic stuff. DKA may be their like initial presenting symptom into diabetes. So if you've got a 13-year-old kid that comes in, they've had some polyuria, some polydipsia, all the P's that go with diabetes, but it's kind of gone unrecognized for the last couple months. They get the flu, now they're altered, they're, sick as stink, might be DKA, but they're not a diabetic. Make sense? So just have that on your radar. Like a teenage kid who gets really sick, gets really altered from what would be a mild illness, maybe DKA. So check a sugar. Any questions about diabetic stuff?
Hey, Doc, we've actually had a ton of questions online.
Oh,
so
goodness.
it might be a good time to catch up before we move on.
Sure.
So we have a really engaged paramedic online whose name is Anonymous User. And so paramedic user wants to know that in paramedic school that we were always stressed to give thiamine when we gave glucagon. How important is this step and why?
So thiamine for hypoglycemia, it should be a consideration. The biggest issue is, Wernicke's encephalopathy. And most of the time you think about it in your patient that's a liver patient or they're alcoholic or emaciated of some other reason. If it's just a patient who has hypoglycemia and they're diabetic and they forgot to eat, it's not a huge issue. But if they have other things going on, then giving thiamine is going to help the uptake of glucose. It's going to help, prevent Wernicke's encephalopathy, things like that.
So it's really not ever harmful to give thiamine.
No. I mean, thiamine is just a B vitamin. It's
Sure.
safe.
So the next question is, it seems like today everybody's taking Ozempic or something similar. Any special problems to watch out for, to consider when dealing with those patients?
So, I mean, it can cause significant hypoglycemia, but it's not as pronounced as like somebody who's taking insulin. The biggest issue with those is the GI issues, the nausea, vomiting, the not wanting to eat. So they may be dehydrated or hypoglycemic from those aspects rather than like an insulin issue.
So
one thing I would say on that is just remember that these meds, Ozempic, Mounjaro, all those meds are approved for type 2. However, you are seeing type 1s taking those medicines now to get their A1C down and kind of prevent those long-term issues like you mentioned. So you can see people on insulin and Ozempic or insulin and some of these pills like the SGLTs, and they're being DKA, but their glucose is normal because they're either peeing off that glucose or that Ozempic has decreased their PO intake and their glucose is just kind of low. So it can kind of muddy the water a little bit for you.
Got you. Apparently, paramedic Anonymous User went back to school and now works in a hospital, and says that when they were in the field, DKA always stressed to give a lot of fluid because they were so dehydrated. But I was humbled when I started to work in ER ICU. We only bolus 10 milliliters per kilogram, with hoping not to cause encephalopathy. So I think you already kind of touched on that. One other question that's interesting is I know a lot of people try to lose weight with a real low carb diet, and they'll measure their ketones because that shows that they're, doing good. Is there something particularly useful in weight loss about the presence of ketones, or is that just a byproduct of the metabolism of fats?
Yeah, it's just a byproduct. So when you have ketones in your urine, when you're doing this low carb diet or keto diet, you're basically changing your metabolism from eating glucose that you're eating to eating, the other things you have in your body. So adipose tissue, things like that. So the byproduct is ketones. So that's why people who are on this keto diet would measure ketones and make sure they're in a state of ketosis.
Yeah, I think a lot of people get confused about that because a lot of the health food stores like GNC sell ketones to take, which doesn't make any
No.
sense to me.
No.
But
I would just avoid giving D50 through an IO at all cost. I would just give the D10 if that's your last option.
Yeah, and that's all you have is D50, yeah.
Yeah.
And like he said, people can die from hypoglycemia. So if your patient is obtunded, you look at that patient, they've got agonal breathing, they look like crap, and the glucose is low, and you can't get IV access, that's the person you drill and give the D10 or D50 to. If they're kind of confused and talking to you, that's not the person that you drill to give D10 or D50 to.
Yeah. IO is your last resort. Peri-arrest, they're
Yeah.
dying. Thyroid stuff. So we're going to talk about the thyroid basics, hypothyroid, hyperthyroid. There's, two ends of the spectrum for all of these things. The thyroid gland is located here, anterior neck. We always talk about like the thyroid cartilage or crikes and things like that, but the thyroid gland is actually a little bit lower, kind of down, just at the top of your chest. And it produces hormones, T3 and T4, very creative naming for the hormones. And it's in response to the thyroid stimulating hormone, again, very creative. And that comes from the hypothalamus. And on the back of the thyroid gland, there's 4 parathyroid glands that are involved in calcium regulation. We're not going to talk about those guys today, though. So hypothyroid, basically this is like a negative feedback kind of system. But with hypothyroid, you're going to have insufficient production of thyroid hormone, either by the thyroid gland, or you're going to have decreased TSH coming from the hypothalamus down. Generally, with hypothyroid, you're going to have slowed cellular metabolism and all the things that go with that. We'll talk about in a minute. Causes, you can have primary, secondary causes. Primary is usually like iodine deficiency, which is not very common in the U.S. because we have iodine in our salt. And contrary to popular belief, you cannot be allergic to iodine, even though your patients will tell you that. If you're allergic to iodine, you're dead. Sorry. But it's also an autoimmune disorder, infection, or medications can cause issues with the thyroid gland. And then secondary is a decrease in the TSH coming from the hypothalamus down. Your prevalence does increase with age, and it's about 10 times more common in females, just because of the autoimmune aspect of it. So hypothyroid, your clinical features: hair loss, depression, fatigue, weight gain, cold intolerance, bradycardia. So basically everything is kind of suppressed. Everything's slower, metabolism slower. Everything that comes with having a slow metabolism is going to be there. So you're cold, you're going to gain weight, you're going to feel fatigued, energy is going to be low. But the extreme of hypothyroidism is this myxedemic coma. And this is usually like an untreated hypothyroidism for years. Okay. Everything is severely depressed. So significant bradycardia, altered mental status, hypotension, hypoventilation. And what you're going to see with this is this like lower extremity edema. And it's called myxedema because it's like a woody edema of the lower extremities. It's like that kind of woody appearance, kind of lovely toenails. And you're going to have like generalized edema as well. So like the puffy eyes, the round face, things like that. So this is like if you Google myxedema coma, these are the pictures you're going to see. So that's kind of the thing. But your patients are going to be hypothermic. So that's kind of a key factor with this. And they can potentially be hemodynamically unstable despite what you do. So you can give them fluids, you can give them pressors. They're not really going to respond until you start giving them thyroid hormone. So, and that's the biggest thing. Has a pretty high mortality rate, 30 to 60%, mainly because it kind of goes unrecognized, right? So if you don't have all the classical features on presentation, you may not, even in the hospital, realize that you've got to give thyroid hormone unless you get there and draw TSH and things like that. So, but they're going to get thyroid hormone for several days in the hospital, and they're definitely going to go to the ICU. So, hyperthyroid, this is your increased circulation of T3 and or T4. A lot of causes, same as the other: infection, autoimmune, medications, or malignancy. And your symptoms is everything is up, right? So tachycardia, heat intolerance, you're hot, you're sweaty. Exophthalmos, where the eyes kind of bulge out. Generally see that in Graves' disease. And you can have a goiter, so swollen, enlarged thyroid. You can have a tremor. So all these kind of things, tachycardia, sweating, tremor, arrhythmias, it's very nonspecific for a lot of things, right? And then the extreme of hyperthyroidism is thyroid storm. So this is an adrenergic overactivity due to the overproduction of those thyroid hormones and increased receptor activity. So everything is upregulated, severely tachycardic. They may be confused, agitated, and again, precipitated by infection, metabolic stressors, and medications. And if not treated, 60 to 80% mortality rate. So that's pretty significant, okay? So you're going to see kind of the same general symptoms as hyperthyroid, but everything's going to be significantly increased. So significant tachycardia, significant hypertension, sweating, tremors, dysrhythmias like AFib, frequent PVCs, and this is like AFib in somebody who doesn't have a history of AFib, right? So they just automatically, or for some reason, went into AFib RVR at a rate of 160, and they have these other symptoms. You can also have some high output heart failure due to the tachycardia. So if you look at them on ultrasound, you're going to have a very large, like dilated cardiomyopathy kind of picture. So just keep that in mind. Treating thyroid storm pre-hospital is just really recognizing it and giving IV hydration and dysrhythmia control as needed. This is kind of going back to the idea of is there something causing the rate being an issue, or is the rate the actual issue? So just think about that. I know some places are carrying beta blockers, maybe an idea, but I would certainly call medical direction before doing any of that because you don't really know the full picture at this point. But a little bit of fluids, probably not going to hurt them. In the hospital, there's 4 steps to treating thyroid storm. We're going to give beta blockers, and this basically blocks the tone, so stops the symptoms. It also, propranolol is the preferred agent because it also has some blockage of the conversion of T4 to T3. And then we're going to stop the synthesis, so we're going to prevent making new thyroid hormone. And this is PTU or methimazole. Methimazole is not the preferred because it is kind of higher side effect profile. And then we're going to block the release with some iodine, and then we're going to give steroids to block the conversion. But generally, the first 2, even in the ED, we're going to do the first 2. The steps 3 and 4, they're going to do upstairs. So going back to one of our cases, 54-year-old man is confused. He's got AFib, hypertension, CAD. He's sitting on the couch, diaphoretic, only knows who he is. He gets mad at you when you ask him questions. He's got an irregular tachycardia, hypertensive, glucose is 96. You guys take him to the hospital because you can't stay there, right? But you don't really know what's going on. You follow up a few days later. He had an undetectably low TSH, so it's a reflex thing. So if they have hyperthyroid, the TSH is going to be low because it's sensing that there's too much thyroid already. So it's that negative feedback loop. He got some propranolol in the ED, helped with his symptoms, got admitted for anti-thyroid management, and he went back home a week later. Any questions about thyroid stuff? No, it's pretty quick. There's only 2 things, right? It's high or it's low. Take him to the hospital.
Yeah, and the way I diagnose hypothyroid in the hospital is my patient is bradycardic and altered, and I treat all the things that I think it could be, and they don't get better. And then the lab comes back 4 hours later, and their TSH is high, T4 is low. Oh, it was hypothyroid.
Yeah.
And the way I diagnose hyperthyroid is I treat all the things that make them a positive sympathetic. Did I say that right? I fix the tachycardia. I treat for sepsis, for meningitis, for drugs, withdrawals, and they don't get better. And then 4 hours later, the lab comes back, and I'll go, oh, crap, it's hyperthyroid. So it's tough to diagnose.
Yeah. Anything else on?
I still can't say.
No. Okay. So adrenal stuff, we're going to talk about basics and then high and low adrenal stuff. So the adrenal gland is located on top of the kidneys. They make hormones, steroids. The 2 steroids are the glucocorticoids and the mineralocorticoids. It also produces your catecholamines, which is your epinephrine, norepinephrine, dopamine, things like that. And it's kind of in different parts of the adrenal gland. It's not really important as to where they come from, but that's where they are. Cortisol is one of the biggest ones. It facilitates your stress response. Has effect on essentially every organ every cell in the body. It'll affect your water secretion, electrolyte balances, fat and protein metabolisms. If it's too high or too low, it's going to have effect on those. The next one is the aldosterone, which is a key part in the renin-angiotensin system. And again, this is like potassium, electrolytes, fluid, blood pressure is a big part of this. So just know that that exists. Adrenal insufficiency. This is where you lack the adrenal hormones, mostly the glucocorticoids, maybe the aldosterone, but glucocorticoids is the big one. In the US, this is usually an autoimmune disease. Worldwide, it's TB. So if you got somebody who's coming over from overseas, they might have TB, might have some adrenal issues as well. And these folks are going to require regular steroid replacement. Most of the time, they're going to take daily steroids. And then you're going to have secondary causes of adrenal insufficiency, where basically something is causing all of it to be low. So if you've got somebody who's taking steroids for other things, like GI issues or rheumatoid arthritis, things like that, it can artificially suppress their body's endogenous production of steroids. So when you have Addison's disease, this is the actual like hypothalamus pituitary adrenal axis of it not producing the hormone. And you're going to have some skin hyperpigmentation, maybe some hypopigmentation with some vitiligo, some skin changes, weight loss, generalized weakness, GI symptoms, some nausea, vomiting, diarrhea, maybe some constipation. So everything's kind of a little bit lower. And then the extreme of that is going to be adrenal crisis. So this is when your body doesn't make any or enough of the steroid to kind of produce or have a stress response. So this is usually precipitated by something like an infection. So they have, most of the time they're going to have known Addison's disease or known adrenal insufficiency, and they get sick and everything is refractory. So you give them fluids, you give them some push dose epi, it doesn't really do anything, right? So the treatment for that is steroids, okay? In your protocols, you do have where you can give hydrocortisone. Most of the time, hydrocortisone is going to be what the patient has with them, and kind of like a rescue pen kind of thing. But you can also give solumedrol or Decadron. Those are within your, like the paramedic protocols. So just be mindful of that. If you've got a prolonged transport, you got somebody who's a known adrenal patient and they're sick, not responding to your fluids or push dose epi, think about steroids, okay? And even in the hospital, if I've got somebody who comes in shocky, septic, I'm going to start fluids, I'm going to start pressors. If it's not working, if I'm thinking about going to a second pressor, I'm going to give steroids. So, and then the other side of this is all things Cushing's. So this is when you have too much cortisol. It doesn't really affect like the thyroid does. So the thyroid, when it's too high, everything is up. This really doesn't do that, but it can cause weight gain, muscle fatigue, weakness. You can have the moon faces, so the like steroid face, if you will. Hypertension, hyperglycemia. So the syndrome is the symptoms, right? Cushing's disease is where your body doesn't produce it, ACTH release, things, mechanisms that I forgot a long time ago. But then you have this Cushing's reflex, hypertension, bradycardia. Does that go with this? What's Cushing's reflex? It's head injury, right? Increased ICP. So hypertension, bradycardia doesn't really go with this. And then Cushing's triad is the reflex plus disordered breathing. So Cushing's was just a guy who wanted to name everything after himself and had stuff. So treating Cushing's syndrome, really don't do anything, just kind of recognize it and kind of go from there. In our third case, so 64-year-old female, general illness. She has rheumatoid arthritis, daily steroids. She's lethargic, confused, pale, looks ill, tachycardic, hypotensive, cool to the touch, glucose is normal. Give her some fluids, push dose epi, doesn't do much. Get her to the hospital, started on some antibiotics, gets more fluids, puts on a levo drip, doesn't really do much. So we give her some steroids, everything kind of gets better. She ultimately goes to the ICU and gets better. So, any questions? concerns, complaints? Anything online?
Nope, great lecture. Very good review. Do you think that this is an off the wall question? There's no reason for you to know the answer to this. Do you think that overproduction of cortisol is a problem with first responders?
Sure. So there's a lot of studies that are out there looking at cortisol levels in first responders, particularly EMS and fire that get up in the middle of the night, because it's a stress response. And generally, your cortisol is going to ebb and flow throughout the day, with the highest, or the lowest being the highest in the morning, around 5, 6 a.m. But if you're getting up at 2 a.m. or midnight, when your body should be sleeping, it's going to artificially rise when it's not supposed to. So yeah, I think there's definitely some correlation with increased cortisol in first responders.
That even just night shift workers alone have increased cortisol and problems, and that's doing 10, 12-hour night shifts. So just imagine what the fire service does. So there's probably some increased risk associated with this.
Yeah. I mean, I think if it's their own and it's a clear adrenal crisis, I think it's within your scope to go ahead and give it.
Yeah, or if you can suggest they take it themselves, either
Yeah.
way. But if you have a question, you can always call Med Control. So the other thing I want to stress, like Dr. Cohen said, was for the flight guys, critical care transports, if you got a patient that is critically ill and you're starting that second pressor, it's time to give some hydrocortisone to those guys.
Very good. Great lectures today. We really appreciate Dr. Cohen, Dr. Kirby. Where are we going to be at next?
We're in Huntsville on, I think, the 25th. And then we're in with Bessemer at UAB West in April, and up in Albertsville at the end of April. And then April 27th and 28th, there's a cadaver lab at UAB. I'm not posted that online yet, but I will. But there'll be some afternoon sessions to come in and do chest decompression and some IO skills. So
please fill out an attendance form, even if you don't need the Con Ed. We want to hear from you and count your attendance. And again, thanks to everybody, and we'll see you next time.